start our webinar by introducing myself. So my name is Hope Newport. I'm the Family Services Manager at the International FOP Association. And today's webinar is on the topic of immunizations and FOP. And this topic has come up a lot with both established members of our community who are really trying to navigate, annual vaccinations. And then, of course, for those families who are newly diagnosed, this is especially when your child is diagnosed early on, childhood immunizations are a really important aspect of daily health for all of us to manage, but especially when you have FOP, there are a lot of complicating factors. So we are excited to have Dr. Chris Scott joining us today to present this webinar. Dr. Scott is a professor of pediatric rheumatology at the University of Ottawa and the Children's Hospital of Eastern Ontario. He is also a chair of the Global Task Force for Pediatric Musculoskeletal Health and is a member and former chair of the International Clinical Council for FOP. And so the information that we're going to be discussing today is information that was really authored by this group, the ICC, or the International Clinical Council on FOP. And this is a group of FOP experts from around the world who work together to provide families and their local healthcare providers with a tool to stay up to date on the current recommendations. So Dr. Scott is an incredible resource for the FOP community, and we're so grateful that he took the time out of his Sunday to be here with us and provide this overview of information. And one thing that's important to note is that the treatment guidelines, which we're going to show a photo of in a minute, is really a tool for healthcare professionals. And so today we're hoping to provide this content in a way that's accessible for families so that you don't have to necessarily go through the work of looking up all of the information. We're hoping that today's presentation is really readily available to you. So just a disclosure to please do contact your local healthcare department for local jurisdiction regarding immunizations and exemptions. The information from the treatment guidelines is geared to be as applicable as possible for the global community, but obviously each person in different countries or different regions is going to have different recommendations. So we really do encourage you to use today as sort of a first step, but to work with your local healthcare team to apply the information. And we're going to be going through a couple of different things to help as family members, you all be able to process the information about immunizations and vaccines. So first, this is a topic that Dr. Scott thought was really important, and I 100% agree that when you are talking with your doctor about immunizations, there can sometimes just be a dynamic that's really delicate, and we want you all to have the tools to be able to advocate as efficiently as possible for. So we're going to start off with that before we dive into, why are vaccines important, what is the history of vaccines, and what are the different ways that they're administered. And then we're going to do overviews of those most common immunizations before going to really some of the more specific ones. But as we're going through vaccinations, we're going to be talking not just about, what is the disease that this vaccine would be protecting you from, but how is this vaccine available, or how can it be delivered? And especially for those with FOP, what are the recommendations for you? And then we just want to end on a really important note that this is a personal topic, which you'll be advocating for yourself and deciding what's best for you on. So with that, I'm going to hand it over to Dr. Scott to get us started.
Thanks so much, Hope, and hello, everyone. And I can just say Hope is also an incredible resource to the FOP community, and thanks for everything you do, Hope. One of the things I want to talk about a lot, or at least just introduce the conversation, is this notion of educating your doctors about FOP and vaccinations. So most of you have had the experience when you were diagnosed or when you were seeing providers for the first time that you're actually ending up as the expert in the room. And many of you are comfortable sort of educating your doctors and walking them through FOP. But this conversation becomes even more delicate when you're talking about vaccines, because vaccines are such a political issue, and because it's become sort of polarizing in a way. Doctors are often very tired of having to advocate for vaccines, and sometimes will immediately take anyone who doesn't want to take a vaccine and assume that their reasons are not scientific or are not clearly thought through. And so this can introduce some kind of misunderstanding with your FOP doctor. So it's important that you sort of just approach this in a way where you're cognizant of that space that you're moving into, and start with sort of trying to understand, does your doctor actually understand FOP? Because if they understand FOP and they've seen the guidelines, and they've spoken to an expert, then they'll know these issues. But if they haven't done all of those things, it may be that you have to explain to them that as much as you understand how vaccines work and why they're important, your child has particular reasons for you being careful or circumspect around giving vaccines in a particular way. I think it's important to make clear that you're not necessarily against vaccinations in general, but that there are particular considerations in your child's health that need to be taken into consideration by your doctor, or by, sometimes these vaccines are given by non-physicians, obviously, and that same scenario can happen there, and it's very easy to, I guess, get lumped in with a group of people who are anti-vax for other non-scientific reasons. So the International Clinical Council, we're a volunteer group of doctors. You can see all the names there on the picture. And we work yearly and throughout the years, actually, to update these guidelines and to take note of new vaccinations, such as what happened with COVID, or take note of new published information on vaccinations, or even new unpublished data on vaccinations that come from the community. And we try and bring you the most up-to-date, high-level information on these things as possible. It's important to realize that for many of the things we do talk about in the FOP guidelines, sometimes it's just expertise and experience that you're hearing, and we don't often have all of the science that we'd like to have, or all of the research having been done, as you'll see when we get to the COVID-19 vaccine. As you know very well, there are very few FOP patients in the world, and so it takes time to gather this experience and this background. One of the things to note, though, is that there are other ways that the people who or the family members, or even people living with FOP can protect other people with FOP or other family members, is by just being vigilant around how you manage infections yourself, and how you reduce the spread of infections within your own environment. This can mean, for instance, that all family members who don't have a contraindication to the certain vaccines in the specified routes should just be sure that they're completely up to date with their vaccinations, because if the family members are all vaccinated, they reduce the chance of exposure of the person living with FOP tremendously. And the same goes with just avoiding bringing infections home, or bringing infections into the home, or spreading them to your loved ones with FOP, as you would with any other vulnerable person, your children, your grandmother, your grandparents, or sick or otherwise unwell people in your house. So you can avoid contact with sick people. If you know someone's got chickenpox, move the play date. Or if you've heard if chickenpox is going around, you can try and avoid these situations. If you're sick, try to stay home. If you feel you're fighting a flu or a cold or some other viral infection, rather avoid social contact. We all got very used to covering our nose and our mouths when we coughed and sneezed during COVID, and wash our hands and so on. Those things still are very important. It's important to develop the practice of not touching your nose, eyes, and mouth all of the time, so that when you have an infection, you tend not it's kind of habit not to do that, because that's a common way to spread infections to other people. And to keep your environment clean and keep your surfaces clean and so on. So those are all things you can do. And there's a link here that Hope's provided for everyday preventative actions to help fight germs like flu that every family should take note of. So where did vaccines start? Well, the whole idea is that the immune system fights better against infections than it has seen before. It's very effective at figuring out which infections have happened to the body, and then figuring out a way of protecting the body against future infections. So the real risk of getting sick from any of these infections is at that first exposure, if you haven't had the infection before. As you know, when some people have had measles or mumps, they tend not to get those infections again. And so the whole idea of vaccinations is to show the body this virus so that in a way that doesn't make them sick, so that they can then, the body can react in the future to the same virus infection as though it had seen the actual infection. And so this started many thousands of years ago, actually, or some thousands of years ago, where in China, there's a history of people having had pulverized smallpox blown into the nostrils of children. So they would take a scab of someone with smallpox, which, as you may know, was a horrific condition which killed 1 out of 3 people that it affected. And they would pulverize these and blow them into the nose and provide that sort of immune stimulus to children, so that when they got the actual infection, they had some exposure to some component of the virus. It was also in the 1700s already known that a minister in Boston had received a gift of a Libyan-born slave who'd lived in the Ottoman Empire, and this slave had scars on his arms from smallpox variolation. That's where they actually took smallpox from another person and introduced it under the skin of a healthy person. And you can see one of those pictures is how that would then react locally. But because that was an unusual way of being exposed to the virus, the body was able to mount a response. And instead of 1 in 3 people dying, it would be 1 in 300 people dying. As you can see, there's some sort of severe reactions documented around that in the picture. And then later on, they figured out that by using the cow smallpox, the bovine or cowpox rather, they could actually inject the same virus and then protect people against smallpox and get a much lesser of a local reaction. So there was enough similarity between the cowpox and the smallpox for the body to be able to mount a response when someone eventually got smallpox. So what are the types of vaccines that we get? Well, there are what we call live attenuated vaccines. Now, these are basically just like giving someone an infection with the virus. The virus is live, but the virus is inactivated or attenuated. So you can think of it as putting someone pulling the claws out of or removing the dangerous parts of a lion, for instance, and then putting someone in a cage with them. You've still got the lion and you've still got the predator around, but they can't harm you because they don't have claws or they don't have teeth. And so that's the thinking behind live attenuated viruses. So they mimic a real virus infection, but they lack the ability to make you very sick. Of course, this only works if your immune system works well. If your immune system doesn't work well, we are concerned that this virus might still be able to cause some damage. But for people with normal immune systems, a live attenuated vaccine is safe. Inactivated viruses can also be injected. So that means they just kill the virus and you really just get the chemical components of the virus injected. And there's no, the virus isn't alive, so it doesn't replicate in your cells and doesn't make more viruses. And the body still learns to recognize the virus through that. Or you could just take a component of the virus or of a bacteria, just a piece of its cell wall, for instance, or a protein that's associated with it, and then you can just inject that protein. And sometimes they would tie that protein to something called an adjuvant, which would boost the immune reaction to that component, and then the body learns to see the virus through that mechanism when it comes in again. And the last and most novel of these is the mRNA vaccine, where you don't actually get the virus or a part of the virus or a part of the bacteria, but you get sort of the message through the messenger RNA. Your body gets the message that you've seen that virus, even though no virus has been in the body. So that's very clever engineering, where you basically, it would be like intercepting instead of getting a letter from someone, the letter would be intercepted, and you just give the letter, but the letter didn't come from the original person. It's been written by someone else. So you give that letter to the DNA of the person, and the DNA makes a viral response based on just the message that they've received, rather than the fact that they've actually seen the virus. Hope wanted to talk a little bit about this slide.
Yeah, and I think now that we've sort of gotten going, I wanted to pause and just give everyone a really important reminder that the information that we're sharing is some of it's very concrete and things that you're learning about, like the different types of viruses that can be included in vaccines. And hopefully, as you're learning about things like this, it's compelling you to feel more committed to educating your social network about why they need to be careful and take precautions around your loved one with FOP, or it's making you feel more compelled to, or more sort of comfortable making decisions about your own vaccine options. And I think a lot of that empowerment that we get through understanding something also happens with children, but they can't understand some of the information that Dr. Scott's providing. So I just wanted to take a minute to say that these books and different videos, which these slides will be available in a PDF form with links, so you can actually click to access the things that we've linked in the slides today. These are great resources for you as a caregiver to share if you're the parent or the loved one of a young child with FOP, because it may not take away all of their anxiety when it comes to actually getting an immunization, but the more they can understand how this is going to help them, the more they're probably going to be on board with helping to move towards that procedure when it happens, and the less anxiety they may have about it when it does. So just a few important points I wanted to share, and great resources to take with you after today as well.
Thanks, Up. A very good point. And don't underestimate the power that children have to kind of spread information and once they understand it and it's introduced to them in a way that they can understand. So, so how do these vaccines then get administered? Well, the first is an intramuscular injection, as you'll see on one of those pictures. Now, of course, as you know, any injury to muscle is a problem, and in FOP specifically for people living with FOP. And so we try and avoid that, because not only does the needle go into the muscle, but if it's for instance, well, any vaccine will cause an immune reaction within that muscle, cause muscle to become inflamed, and that inflammation within the muscle can trigger a flare-up. So that's really one of the main things about immunization and FOP that we have to learn, is that injecting the muscle is contraindicated. The other way that it can be introduced is just by pinching up the skin, as you can see on this to the right of that slide, where you inject it just under the skin, but you stop short of the muscle. So the muscle itself doesn't get inflamed, but the immune cells that need to see this virus or this component of the virus, they're able to access it just by virtue of it having been injected just under the skin into the subcutaneous layer there. Other ways it can be given is by mimicking the way we catch most of our viruses, by getting it injected into the nose. For instance, some flu vaccines are available like that, where you just get it into the nose through the nasal mucosa, and the body sees it the way it normally would have. And then there are nowadays patches that can be applied, to the skin, where it works a little bit like subcutaneous injection, but there's no painful injection. It just makes small marks in the skin, and provides entry for the vaccine to make contact with the immune system under the skin. So one of the other things to know about FOP and vaccination is that when someone's having an active flare-up, we don't want to mess with the immune system at all. All of these things trigger the immune system, and if you've just had a flare-up or you're in the middle of a flare-up, having another immune response or something that flares up your immune system, which a vaccine is designed to do, we want to avoid that. So absolutely avoid it within 2 weeks of flare-up or flare-up-like symptoms. But if you can, and if it's not urgent, just wait at least 6 to 8 weeks before you get that, so that you're well sure that the inflammation around the flare-up is settled, and that you come in sort of on a blank slate, and you don't have underlying inflammation at the time that you give the vaccine, because then you're just adding fuel to the fire. The other thing is, if you are going to inject, and then sometimes you might choose to take an intramuscular vaccine, as many people chose to do during COVID, then inject it depending on the age of the child, of course, or the person receiving the vaccination. There may be areas that are already affected, that have a lot of bone, that are completely ossified, and there, the chances of doing harm by doing an injection is really lower. So try and inject over an area where there's skin or muscle, but which is already affected, and where having new bone isn't going to cause a new problem. So don't take an arm or a leg or something that's moving perfectly well and take the risk of doing an injection there. As far as possible, go for areas that are already limited or affected. And also, again, just to try and dampen down the immune system by reducing things like fever and the immune response in general, you can use Tylenol or Advil or in some parts of the world called paracetamol or ibuprofen or similar drugs, non-steroidal anti-inflammatory drugs, just to get ahead of the game. Many of you have had most of you will have had many immunizations, and you know that the muscle pain that comes from a vaccination is something that you're very aware of. Some of you will have had fever after a vaccine, etc. These things will just help to reduce that immune response. All of those things, the pain and the fever, are actually your immune system getting to work at identifying and killing this virus. So if you take some ibuprofen or some Tylenol, you can get ahead of that and reduce the level of inflammation that's being caused in the muscles without necessarily affecting the efficacy of the vaccine. And another very important thing is, if you are in a clinical trial, absolutely every vaccine you take or any medicine that you take needs to be discussed with your clinical trial doctors before you decide to do anything. Depending on the trial, that might cause you not to be able to participate in the trial any longer, or there might be particular risks with particular vaccines that you need to consider. So by all means, if you're in a trial, don't do anything without discussing with your trial doctor. So we'll talk about the flu a lot. We all get the flu. We'll call in sick and say, I've got the flu. But the proper influenza is a really deadly disease. And we've sort of gotten used to it. And many people don't tend to get very that sick anymore or tend to die, partly because we have vaccines, partly because our healthcare systems are better, and partly because we call things that are just a common cold, we sometimes call them the flu. And so we don't really know when a real flu outbreak is happening. But influenza can cause high fever, muscle aches, joint pains, chills, all the stuff you've known about: vomiting, diarrhea, sore throat, headache. People who've had real flu get really sick. And it's not long ago, it's in the time of my grandmother and many of your great-grandmothers and grandfathers' time, that nearly 50 million people across the world died from the 1918 flu pandemic. That's a picture of a hall where they were trying to get people better. So flu is a serious infection, and especially if you have underlying lung problems, as many people living with FOP do. This is or you're taking medicines that bring down your immune system, which is also increasingly likely in many people with FOP. This virus can have serious consequences. Usually this is given intramuscularly. So again, we don't like intramuscular injections, so we wouldn't advocate that people do that. What we advocate is that people use the regular intramuscular vaccine, but just administer it subcutaneously. We've got experience that this appears to be safe for people with FOP. There's a live attenuated virus, as I've explained, a virus that's going to live and replicate in your body, that is available in intranasal forms. But Dr. Kaplan and others have noticed that that these vaccines, because they cause quite a profound immune response, actually can trigger flare-ups. So we try and avoid those. Depending on the type of, the flu vaccine gets remade every year based on the strain that's circulating and other factors. And some years there's a transdermal or an intradermal vaccine that is available, like the patch vaccine. So in years that is the case, we would advocate that you try and take that vaccine. It's not every year that the scientists are able to produce these types of vaccines, but I guess increasingly it'll be more common to have the patches and the intradermal routes available. If they're not available, then we recommend getting them done subcutaneously. Just a note, this isn't a vaccine, but antivirals can be used in people who get actual flu. So if you've got flu, or you're being diagnosed with flu, and there's a strain going around, and your nose and your swab comes back positive, or you've got or features that are very convincing of flu, you could use oseltamivir, also known as Tamiflu. This has been shown to reduce the duration and the intensity of sickness in some people with underlying risk factors. And if you're one of those people, specifically, for instance, with lung issues already, then you can get your provider to provide you with some Tamiflu that you could keep at home. And you could start if you suspect that you've got a flu, an actual influenza infection. It doesn't really work for the common cold or for other things, and often, I guess, people are not sure, and they'll start using it for infections that are not the flu. But if you know that there's an influenza going around, you know you're not immunized, and you get proof that you've had a flu infection, then this can be used to try and minimize your how sick you get it doesn't kill it, it doesn't cure you completely, but it will just make sure that it reduces the intensity of things significantly. COVID-19 was I don't have to tell any of you what COVID-19 is. And we were, for the first time, introduced to mRNA vaccines. And so COVID-19, some of the vaccines were mRNA vaccines. And also, because they're so new, we don't have any experience with these vaccines being given in routes other than what is prescribed by the people who designed the vaccines. And so we haven't been able to come up with solid recommendations on how you should go about taking the COVID vaccine. And it really comes down to a discussion between you and your healthcare provider, considering the risk of COVID, your particular case of how the person living with FOP, how severe their underlying ossification pattern is, or how many joints are already affected, the risk of how much, how bad they are from a lung perspective, etc. All of those need to be considered, and then you need to make a choice. We don't know how effective the vaccine is when given under the skin, and we don't know if it's safe to be given under the skin either. Dr. Shao did some research with some FOP patients. You'll see there where 23 FOP patients received the intramuscular COVID-19 vaccination. And again, the recommendation was that the intramuscular vaccine would be given in an area already ossified or over an area already ossified. We found that the most common symptoms were just pain and soreness, the same as all of us experienced with these vaccines, tiredness and swelling. And 1 out of 23 people, however, who got this vaccine developed a flare-up. Of course, that doesn't prove that was the cause of the flare-up, but 1 out of 23 people happened to develop a flare-up as well. And so it could well be that the vaccine played a role. But no one who received the vaccine was hospitalized. They also had 19 families or people living with FOP developed actual COVID-19 infection. And these people developed fatigue, loss of smell or taste and cough. And 2 out of the people who actually got COVID-19 developed flare-ups, and 3 patients were hospitalized. So that's very limited number of cases, but you can sort of use that at least as some kind of information to try and decide how you will take this forward. And we'll probably develop more evidence as time goes on. Now we get to the old conditions, the conditions that are nowadays so rare because people have been vaccinated by them, so that people sort of almost tend to forget how severe or how terrible these infections were. Diphtheria is the DPT vaccine is usually given in combination. It's one of the most sort of potent vaccines. It has a really powerful response. It has quite a lot of vaccine side effects in general. And so just to talk about diphtheria, first of all, it causes these swelling of the back part of the throat and can really block up the airway. You can see there in that picture at the top, that child's neck becomes like a bull neck, a lot of swelling around the airway, which can actually close up the airway and cause breathing problems and can be fatal as well. And before the 70s, in some areas of the world where this vaccine wasn't available, the death rate from this was something like 7,000 per million people, which is really enormous if you think about it. So this is I've had a few suspected cases of this in my life, and it's always terrifying. because it's a really serious condition. Tetanus, we all know about tetanus shots and so on. Luckily, we don't see that much anymore, but you can get the bacteria introduced through a wound in your skin from a rusty or an old nail or a dirty nail or something. And this tetanus makes a toxin that causes the muscles to contract and can actually cause you to become very, very stiff, unable to breathe and unable to move and unable to swallow. This is also a potentially fatal condition. It works straight in the brain as well. And then there's pertussis. Pertussis is perhaps out of these three, the one that's still around them, definitely the one that's still around the most, but it's also one that can be dangerous in children, but it probably not quite as dangerous as the other two. Pertussis was known as, in the old days, was known as the 100 days cough. And we're seeing a lot more pertussis nowadays, possibly in part because people are reluctant to vaccinate. These coughing spells can be so bad that you could break your ribs, or you can struggle to eat and drink. And in younger children, it can be a very serious condition. So pertussis is not to be toyed with, but one that we see more than the others. So these three are then combined into a vaccine. And because they have quite a profound immune response, they cause quite a strong immune response. That immune response has been associated with causing flare-ups, even when it's given in the subcutaneous way. So the current recommendations are that these vaccines, not even subcutaneously, should be recommended for FOP because of the experience that they actually tend to cause flare-ups. Fortunately, as I said, these conditions are now rare, and something like pertussis does have effective antibiotic therapy. And unfortunately, though, a lot of children will have had these vaccines before they even get a diagnosis of FOP, which also is in no way a good thing. Measles, mumps, and rubella. Measles, there's been flare-ups in many parts of the world. I lived through an epidemic or an epidemic in Cape Town, where I used to practice a few years ago. And let me assure you that it is a significantly nasty virus. It causes and we saw many children die during that episode in Cape Town. We saw many left with permanent brain damage. I actually got measles myself at that time, and I had colleagues who developed measles as well, who ended up in intensive care units and so on. So it is a really severe infection, and immunization is definitely our best answer to it. Mumps is not quite as severe. It causes inflammation and swelling of the salivary glands, the parotid glands, and so on. It can also affect boys, though, by infecting their testicles. It can cause permanent damage to and affect their ability to have children. And then rubella, which is called German measles, even though it's got nothing to do with this, it's a totally different virus to the regular measles virus. Causes a lot of symptoms, but the main risk there is actually for unborn children, where children can develop cataracts, they can get heart lesions, tubes that don't close, and holes in the heart, and that sort of thing. And they can also develop quite severe brain damage in utero if their mothers develop rubella. So congenital rubella syndrome is something I have seen some of, and it is a very severe condition. Fortunately, these vaccines are all subcutaneous, and they're recommended for everyone subcutaneously, and there's evidence that they're safe in people with FOP. You'll all know, we didn't actually put this in the slide, but there's been this, there was this episode where a doctor in the UK incorrectly identified mumps as being, or the MMR vaccine at least, as being implicated in causing autism. And that's been thoroughly debunked, and that doctor has lost his license to practice and so on. So we really recognize that there's no association between MMR vaccine and autism. Inactivated polio vaccine, this is polio is a condition that's also very, very severe. It causes paralysis of the nerves. And this slide you see is one of the slides that I always think of as one of the most horrific slides, or one of the most horrific times in medicine that I can think of, was during the big polio epidemics. This slide is from the USA, where many children were unable to breathe because the nerves running to their breathing lungs and their breathing muscles and their diaphragms would become affected. So they would be dependent on ventilators or respirators, as they were called. And in the old days, they didn't put the ventilator, you couldn't be ventilated by having a tube inserted into your throat. That technology didn't exist yet. So they built these ventilators where you were sort of stuck in a vacuum tube, and then they'd create a vacuum in the tube, and that would allow air to rush in. If your head was outside, air would then rush in through your mouth and in through your nose and into your chest as the vacuum around your chest was created. So these tubes these children are lying in, and they would be lying there for months on end, where they would be stuck in those tubes just to be able to breathe for all of that time. You can imagine how horrific that is. So FOP is not, polio is not a thing we see very often anymore. It's been virtually eradicated, although there have been some cases not too long ago in a number of African countries. But certainly to be avoided, and thanks to immunizations, the world is almost rid of this disease. And certainly we'll keep immunizing against it. Again, this is a vaccine. I'm sorry, that slide just doesn't emphasize it very well, but the inactivated polio vaccine is safe as well and can be given subcutaneously to people with FOP. The 23-valent polysaccharide vaccine, that just means against pneumococcus. The 23-valent means there are 23 different subtypes or sort of species of pneumococcus. And pneumococcus is a streptococcus bacteria that causes pneumonia and meningitis and can cause skin infections as well. This is something I've seen a lot of in my life. And the meningitis and the pneumonia from this condition is absolutely deadly. This vaccination can protect you against that. Again, it's something that's recommended as subcutaneous, and it appears to be safe for people with FOP. And this is certainly one I would strongly recommend. Hepatitis A, there are 3 forms of hepatitis. We'll talk about hepatitis A and B here. But hepatitis A is a serious liver disease. It causes jaundice. As your liver starts malfunctioning, you develop jaundice. It can be very serious in young children. I've seen some very serious cases of this in my work and in my life as well. I've seen a number of children die from hepatitis A. So although the majority of people survive this and do well, but it can cause you to be sick for a very, very long time. But hepatitis A is also something that you can avoid through the vaccine, and this also appears to be safe for FOP and is designed to be given subcutaneously. Hepatitis B is a sort of a more chronic infection that can cause liver problems and is implicated in developing other issues like liver cancer and so on. Hepatitis B is also supposed to be given intramuscularly, or in this case is supposed to be given intramuscularly, but if given by the subcutaneous route, it's felt to be safe for people living with FOP. This is something that's still very prevalent in many parts of the world, and it's part of most immunization programs now to get your hepatitis B vaccination. It's spread mostly through contamination or through contact with human secretions like blood and feces and urine and so on. The meningococcal serogroup B vaccine, there are several serogroups again, just like with the pneumococcal, there are several types. Depending on where you live in the world, it could be group C or group B that mostly causes the problem. In North America, group B is the more important one. And this causes meningitis, which is inflammation around the brain and spine. It's one of the most serious conditions we as pediatricians see, and the best way to avoid it is obviously immunization. It spreads in groups like in schools and in hostels and so on. So this is definitely a recommended vaccine, and the outcomes of meningococcal infection, if not treated early, are always terrible. So it's recommended to be given intramuscularly, but it's probably also safe to be given subcutaneously for people with FOP. The HPV vaccine, the genital human papillomavirus, this is a sexually transmitted condition. And so in the last decade or so, we've been immunizing teenagers, young women and girls and boys against this. HPV can cause these warts and so on in the genital area, but they're very strongly implicated in cervical cancer as well. So it's really a long-term health condition, and is very effective in preventing the cervical cancer that comes from having had HPV. So this is also recommended as an IM vaccine, but in FOP should be given subcutaneously, and it's known as Gardasil. Many of you will have had experience. This is probably one of the vaccines that young people with FOP will have been diagnosed with before requiring the vaccine. So it's a very important one. Rotavirus, I was fortunate in my life to see the effect of the rotavirus vaccine, working in South Africa in the 80s, 90s, and early 2000s. Literally, this was a virus that killed thousands of children every year. And it causes diarrhea, it causes severe diarrhea. Nowadays, the vaccine is available. I saw this vaccine introduced in Cape Town, and the situation was so much better in the years following this vaccine than it was before. It's an oral vaccine that contains the live virus. It's given at the age of 2 to 6 months. Most people at FOP will have had this vaccine before they're diagnosed anyway. So it's really one of the vaccines that and also rotavirus is actually quite common. So most people have immunity by the time they're diagnosed anyway. It's really in those young children who develop gastroenteritis between 2 and 6 months, where it's really, really deadly. So that's just for your information. We don't really have specific guidelines on whether to give this or not. It is a live vaccine, however. The zoster vaccine, zoster is something that happens in immunocompromised people or people who've had their immune systems affected. So if you're taking immunosuppression, like some of the drugs that are increasingly being used off-label for FOP, and it's also it can also occur in people over 50 years of old to prevent shingles. Shingles is a very painful condition where the virus that's been living inside your nerves for many years, you probably pick these infections up as a child, but then the virus becomes active once you get older and your immune system changes. It's a live virus vaccine, but this can be given subcutaneously to people over 50. And again, in this age group of people with FOP, most people have significant or severe ossifications at that time, and so we feel this is one that should be given. There are a number of other vaccines. I think we're running out of time, but another bunch of vaccines: Japanese encephalitis vaccine, tuberculosis vaccine, typhoid fever, and yellow fever vaccine. These are for specific areas and parts of the world, and they become important when you travel. But so if you're going to an area of risk and you read your travel advisory and you need one of these vaccines, it's best just to consult the guidelines and talk to your healthcare provider. And so lastly, the decision on how you go about all of this is absolutely a personal one. And what we try and do is provide all of the information that's available, and you need to make your choice based on that and based on your personal circumstances and your discussion with your doctor and what medicine you're on, etc. And you need to consider the risks and benefits of all of these, and your own environment. Whether you're going to be living in a hostel, or you're going to be living in a crowded area, or whether you're going to be mostly avoiding people with other infections and so on. But it is important that you just discuss these things very directly with your healthcare providers so that the air is clear and everyone understands why you're making the decisions that you're making, and so that they can support you in making the right decisions. I'm going to stop there in case there are any questions. Thanks so much for listening, and I hope that was helpful. Thanks, Hope.
Thank you, Dr. Scott. And if you do have questions, please do feel free to put those in the Q&A or chat at the bottom of your screen. But one thing that I would love to just kind of talk through a little bit more with you, Dr. Scott, is regarding, sometimes it is a decision not to have a vaccine, but other times it's really a request to the provider who's providing that vaccine to say, I need to have the vaccine this way, subcutaneously most often, instead of the traditional intramuscular route. And I guess I would love to hear, like, what are your recommendations if you come into contact with someone who says, that's not how we give this vaccine. We have to give it this way. Because sometimes there are members of the healthcare team who are not as apt to listen to us when we're advocating. So, I have a few thoughts, but I'd love first to hear from you, Dr. Scott, if there are things that you would recommend if you come into contact with someone who's not necessarily listening when you're speaking up and advocating for your needs.
Yeah. And we've had this situation, and my response is always, as a physician, but also someone who's sees physicians. Obviously, all of us are patients as well. If you're relying on a doctor or a healthcare worker who is totally against listening to other people's advice, or exploring the evidence with you, or communicating openly around complex medical issues, for me, that's a warning sign, because the days of doing medicine like that, where what the doctor says goes, they're over in a way. Like, everyone's got access to information. Everyone's got a clear understanding of their rights as a patient. And people are increasingly and correctly empowered to be able to make the right decisions for themselves. So if you come up against a healthcare worker who just says, no, my way or the highway, it's going to be intramuscular, and it's going to be in the thigh. I don't care what you say, even if that's the way I've always done it. My advice is honestly to seek alternative help.
Yeah, and I know
Your feelings.
depending on different family dynamics or different cultures, that can be a really hard thing for some of our families to do. But I think this is one topic in particular where, we would encourage and empower, and, however we can work with families to partner them, whether it's by creating a script that you can use when talking with a provider, or whether it's kind of coaching through, here are maybe some other ways to look for a provider if the one you have is not a good fit. And sometimes patients and families are in a position where they have to sort of do the hiring and firing, so to speak, of their own healthcare provider team. So I hope that that's a circumstance none of our families come in contact with, that you've all developed relationships with your doctors that are collaborative. But I just think it's important to say out loud that if you are working with a provider who's not listening, that is an important thing to consider to pursue.
Yeah, and from the ICC, or as a clinician looking after people with FOP, I don't know any FOP clinician who won't have your back on something like this, and who won't write a letter in support, and try and lay out the evidence and try and help you convince that healthcare provider of what's happening. So reach out for help, and the best is always to try and onboard people, and to convince them to change. But I completely understand it's depending on where you are in the world, and your socioeconomic circumstances, and the cultural influence, and the hierarchical strength of the hierarchical system varies across the world, and it can be incredibly difficult. But when it comes down to it, you've always got to think, what's the best thing for my child? And if that thing is going against, that's the only consideration. What's the best thing for my child? And everything else must make way for what's in the best interest of your child. That's it.
Yeah. Well, and being here on a Sunday, Dr. Scott is a great example of, I think, what he mentioned, which is that the FOP community, whether it's the International Clinical Council that he explained earlier as a volunteer group of doctors or staff at the IFOPA, we are all very invested, I think, in supporting one another to the best of our ability. So please do feel free to tap into that network of support. And I want to thank you again, Dr. Scott, for being here today, for putting together this wonderful presentation, and thank you to our audience. This recording will be available on YouTube, and we will have a PDF of our slides so that you can go back and access both the content that Dr. Scott shared, but then as well some of the resources that we had linked in the presentation. So I want to thank you, everyone, for joining us, and have a great rest of your day.
Thanks, everyone. Bye-bye.